Okay. Well, firstly, thank you very much for the invitation to present. And you said at the start it was a brilliant presentation. So before anybody kind of says anything at the end, I'll take that, Caroline, from you. Thank you very much. I'm Peter Robinson-Smith, and I'm one of the liver transplant coordinators here at Freeman. And to my right-hand side is my colleague Siobhan Davison, who is also a liver transplant coordinator. And our improvement presentation is regarding day case assessment for liver transplantation. We're just kind of starting with the idea of what it is that we're going to talk about. And for those of you who think he hasn't actually written anything on this slide, it was kind of because what we started with at the start of this presentation, which as a team we felt was really important, was we actually had a blank page. We knew we needed to do some work to look at our assessment process for liver transplant, but actually the page was empty. We had a complete blank canvas. We had an existing process in place, but we needed to improve it and we needed to go about trying to sort that out. So firstly, I should talk about what we do and the point of a liver transplant assessment. So the liver transplant assessment is to look at people who have chronic liver disease that is heading towards transplantation, and the assessment is to work out whether or not this is a suitable course of treatment for those patients. So as many of you will know, liver transplantation is a specialist service. So we operate both a regional and a super-regional service. And then for liver transplant in conjunction with heart and lung transplantation, we operate a national service. So various things are really important in liver transplantation. One is education. The second is the timing of an assessment. Too late in somebody's disease process and transplantation is not going to be indicated because they're going to be too sick, or too early in the process and actually transplant won't be of benefit and the patient won't be at the point where transplantation is required. So that's key to the success of all of this. And secondly is what we are going to talk about is teamwork and good and effective teamwork, which is one of our trust themes, but making sure and giving examples of it are what we're trying to do here. So as with any MDT, Siobhan and I as transplant coordinators are part of a wider team. So we're made up of 8 transplant hepatologists who are consultant medics. We've got 8 consultant transplant surgeons. We've also got a team of 7 consultant anaesthetists. There's 2 transplant coordinators and then a liver social worker and a specialist dietitian. And as transplant coordinators, we just thought we'd give a little bit about our role as well. So we are one part of the whole liver transplant MDT. We think we're quite important in that, and so do our colleagues, but we're just one cog in that wheel. And our goal in our day-to-day work is to guide and advocate and support patients and their families throughout the whole of the transplant journey. So from the point where they're first referred into this service, right up until the point that that recipient either is not for transplantation or passes away at the end of that journey. We are here for every single step of that. Some people need more help than others, as with any kind of patient journey, and we're here for those as well as the ones who don't need much. We manage a pre-assessment transplant clinic, which we'll come on to later on. Siobhan and I organised the transplant assessment day. We booked the patients in for that. We organised the tests and we ensure that those tests are completed on their assessment day. We then, while a patient's on a waiting list, we organise and run a clinic for them so they have a point of contact. Them and their families can come to a waiting list clinic once a week. We act as educators for their families and for the patients lifelong. And then once they've been transplanted, we do a post-transplant annual review clinic. So as I say, that's for the rest of that patient's transplant life. And our little project is based, we use this quote because we started this project quite a long time ago, about 2016, but we came across various obstacles, and at various points it would be easy to give up, but persistence will pay off. And as nurses, we do understand that in an MDT, we sometimes have to nag in order to get what we think is right for the patient. So as I say, in 2016, we started the discussions regarding the project of day case assessment. So we used to traditionally see our patients for 3 days, but we wanted to make that a better way of assessing for patients. So we went down to Leeds to have a look at how they organise day case assessment, and then to Birmingham to see how they work their systems. Leeds, because their assessment programme was around about the same size as ours was in 2016. And it was very close. We've got very good links with them. And Birmingham, because they're the biggest liver transplant centre in the country, and so they operate a much broader system than ours. So we went to have a look at them, but we didn't go on and develop a service then, because our MDT was very different to how it is set up now, with some very different personalities who weren't engaged, I think is the best way to describe it, with day case assessment and shortening the amount of time we saw patients for. Then in 2019, we had further discussions and sat down with one of our consultant hepatologists who's on this call as well, and a consultant anaesthetist who's also on the call, to look at how we could smarten up our assessment process. And I'll come on in a moment to talk about what smartening up means. But it was a discussion to look at it. But again, we didn't proceed to developing a new assessment service. But importantly, we identified the need to change and work out what we needed to change. And so we went away to look at those things in more detail with a plan to rediscuss that. So that was late 2019. And then March 2020, obviously, as we're all aware, the kind of an outpatient service kind of stopped here at Freeman while COVID wreaked its havoc. So all of our transplant assessment, whether 3 days or 1 day, stopped at that point. And we very quickly had to come up with a new way of assessing patients who were outpatients who required inpatient beds. So we very quickly threw together a 1 day case assessment and crammed 3 days into 1 day's work. And then we got that ratified by our wider MDT 2 months after we'd started, and that was on the 22nd of June in 2020. So this is what originally our assessment process looked like. So it was a 3-day assessment with 2 days, 2 overnight stays. So the patient arrived, it says PM on a Wednesday, but basically at some point between 9 o'clock and 1 o'clock, the patients arrived onto Ward 12's day room. And that was part of what we needed to smarten up. And this is why I talk about smartening up, because this was a very ad hoc system. So at some point on a Wednesday morning, the patients would arrive and the first test would be in the afternoon. And then they had a full day of tests on a Thursday, and then they went home on Friday lunchtime. And then we had an MDT every 2 weeks on a Monday evening to discuss the outcome of the assessment. And when we look back at the numbers of these patients, so this is people coming for routine transplant assessments as outpatient, from an outpatient referral. So this doesn't include super urgent patients who require a transplant within 72 hours. This doesn't include inpatient assessments where somebody's come in and the need for transplant is identified. So of these patients, we had 102. So the total bed days we used in the financial year until the end of March 2020 was 200. Of those 102 patients, we listed 44 as active, 41 were not for transplantation, and then we deferred 17 patients because they required further testing. But this assessment process needed smartening up because we didn't have fixed slots for our tests. So each week on a Monday, we would go around CT or Clinic H to organise CPEX tests or liver scans, and they would slot our patients in. So we often had scans on different days from week to week. So they weren't fixed, and so the patient could often, it was not uncommon to have a CT scan and a CPEX bike test on a Friday morning as they went home that afternoon. So often the outcome of these tests wasn't known at discharge, and then education that was required from that wasn't completed. So it wasn't, we had the patients for a lot of time, like 72 hours, but we didn't do some simple things. And so that meant patients often came back 3 or 4 times for 1 or 2 tests. And that also meant repeated discussions at MDT. So not only were we using up valuable patient time, we used up valuable MDT time. Patients often waited greater than 10 weeks for their assessment appointment. So they'd be seen in an outpatient clinic and then not again before their assessment. So things like paracentesis, which is a drain for patients with acidic buildup, fluid buildup in their abdomens, they weren't performed before they arrived for assessment. Patients who were anemic weren't transfused before we tried to put them on an exercise bike. And so they weren't optimized for their assessments. And often, as I say, patients weren't seen in the clinic before their assessment. So any new issues that arose in that 10 weeks weren't identified. And we also felt that 200 inpatient bed days was an avoidable financial cost to the trust. And as we all know, everything comes back to finance, and where possible, if we can save money, then prior to COVID as well, that was something we were trying to do. So what we did is we realized that it's great thinking that we'd rather have patients for 1 day than 3 days, but we wanted to find out what the patients thought, because really, at the end of the day, they are the most important people in this process. It's not my time or Siobhan's time or a hepatologist or surgical time. It's a patient getting a valuable assessment, and the way in which it works should be beneficial for them. So we decided to send out a questionnaire to everybody who'd been assessed the previous year. And we also did a questionnaire because some of the DT still weren't in agreement that a 1 day assessment would work. So right back in April 2020, we sent out this questionnaire. And some of the responses we got back when we asked about a 1 day assessment was that they didn't want to spend an evening or overnight in hospital. Although they lived quite far away, they felt it would be more convenient just to come for 1 full day rather than 3. They felt that it was a waste of a bed if tests were taking 3 days when it could just be done in 1 day. They felt, one of them thought that a more coordinated appointment time would result in less waiting around. And I think we've put that in because that was a bit of a slap in the face for us as the people who organised the assessment, that the patient didn't feel it was coordinated. But again, if you're going to do something that you're going to work to improve on, you've got to be prepared to take the things that are personal, that you worry about, where somebody's saying your work isn't good enough. And that we've put that in because that's probably the one that spurred us on most of all, that somebody thought what we were doing wasn't coordinated despite our best efforts. And so we sent out 70 questionnaires and got 34 responses, and some of those responses are there. But there was overwhelming support from those 34 for day case assessment. So it was 24 of the 34 felt this would be beneficial. And so in March 2020, COVID struck, and one of our consultants coined this phrase, that out of adversity comes opportunity. And really, if we did want to make changes to anything, whether it's assessment, whether it's the way we work as an MDT, then actually this was the time to do it. We had nothing, we had people on the wards, but a lot of the outpatient stuff had stopped, and there was this kind of hiatus, as we all are aware, in March and April of 2020. So we really sat down and put our heads together to come up with something better that would work for us. So we came up with a 1 day assessment. So as you can see, that's all, just everything that was done in 3 days is now being done in 1 day in this incarnation. So we went round in that period of time to speak to CT, to speak to Clinic H, to speak to our anaesthetists, our psychiatry colleagues, to fix our slots, so that actually when it says on a timetable they are going to be seen, they are going to be seen in those slots. And this took a lot of negotiation. We endeavour where possible to not have overnight stays, although there are exclusion criteria, and I'll come on to those in a minute. But actually, it's far easier to manage tests when you say to somebody they're just here today. If you say to somebody that they're here until Friday afternoon when they're finished, things get put off until Friday afternoon. If they're only here till 4 o'clock, they have to be done by 4 o'clock. So departments don't have a lot of wiggle room to get out of things. In this scenario, patients were seen first thing in the morning when they arrived, so around about 8 o'clock, by a liver registrar, and the bloods were ordered, blood gases done, and then they went off at 8:40 for their echo. So it was a lot of legwork for Siobhan and I actually getting patients to tests on time, because as you're all aware, at that time in the morning, porters are busy, other departments are busy. So physically, as Band 7 nurses, we take them around to their appointments. We also, in terms of fixing slots, we then moved to a weekly transplant MGT to discuss the assessment patients, and this therefore led to a quicker outcome for the patients. The exclusion criteria we mentioned were anybody who was severely encephalopathic. So encephalopathy is a specific kind of confusion that exists in liver disease, and it's related to ammonia buildup and then a confusion that can appear as if somebody's drunk or is kind of demented. So, but I realise demented is not really the greatest term, but I couldn't really think of a better one at that moment, so I'm sorry for that if that's wrong. If somebody needed acidic or pleural drainage, then that would be an exclusion criteria. Anybody with recurrent anemia, anybody that required a further test, so somebody who was coming with hepatorespiratory syndrome and needed a bubble echo, they would be excluded because we needed to get more tests fitted into that one day. And then for a one-day assessment, we excluded people who were the far side of Carlisle, so anybody in the west of Cumbria who couldn't get here realistically for 8:30 in the morning, or south of Middlesbrough. Although I'll come on to what we've changed in a minute. And anybody who was coming for a lung liver or heart liver transplant was not considered. And so we assessed in the following year for routine assessment 88 patients. So between the first one of our day case was in the end of April, as I said earlier on. So there was a few, about 10 or 12 from March who didn't, and the start of April didn't get assessed. So 88 patients, and we used in that financial year 7 bed days. So we saved 193 bed days. We made of those 88, 38 active, and we declined 41, and we deferred 9. And I want to pick up on those patients that were the less patients that we deferred, because the reason we deferred less patients was because we were much smarter in who we assessed on a one-day thing. So people who had had a paracentesis, we went away and spoke to their local services. So if they were getting a paracentesis done at North Tees in Stockton, we spoke to Stockton and we improved our referral hospital relationships. So actually one of the key changes we made was that we list a higher percentage, but we also defer less patients. So in this, what did we change? So we changed our referral pathway, and we made our assessment day one day only, and it's from 8:15 till 5 o'clock, and it's always on Ward 4, the day treatment centre. So all of our MDT members are at that point were engaged. They had slots where they could see the patients on the day, and we made sure they were seen. And as I said a moment ago, we improved our relationships with referring hospitals, and we made a more regular MDT. And this is what the referral pathway looked like then. So it was a referral direct to a hepatologist, and the patient was reviewed within 4 weeks of that referral. When they came to the outpatient clinic, we as transplant coordinators went to see them, and we made a decision regarding inpatient or outpatient assessment, and we gave them a date. And then we assessed them on that date on Ward 4, and we spoke about them 1 week later on. But as with anything, the first incarnation of a change was not perfect. And in a PDSA cycle, which we used to assess ourselves, we need to look at continual evolution, as the cycle says. So we had a good look at it about 6 months ago. And what we found was it still wasn't as good as we wanted it to do. And there was a lot of time pressure first thing in the morning. The patient was coming in the door between 8 and 8:15. They were seen immediately by a registrar. They had bloods taken straight away, and they had an arterial blood gas, and then they were whipped straight away to echo. So actually it felt very rushed. And if for whatever reason the patient was late, whether it was transport problems, whether it was just traffic, that got pushed later in the day. And it always felt like the start was a very busy. there wasn't huge amounts of time to give education. So what we did was we introduced a weekly transplant coordinator pre-assessment clinic. And I said at the start, that's something that Siobhan and I run. So every week on a Tuesday, we see the patients for the following week in a pre-assessment clinic so that we can identify any issues that require optimization. So there were still some anemic patients slipping through, and there were still patients who turned up requiring paracentesis. We brought relatives into that pre-assessment clinic to allow education with them, because as we're all aware, relatives understand different things from an appointment than patients do. And so in transplantation, that's really key. And so the patient and the relatives were reviewed to give greater time to allow them to understand what we were going to do. And so in our referral pathway, it's even further improved by having a transplant coordinator clinic 1 week before then. And in that clinic, they're also seen by a liver unit registrar. All of their medical clerking is done, blood gas is taken, and all of their assessment bloods are completed. And so that's added another step in, which has improved that. Going forward, what we want to do in continual evolution is to offer our deferred and our declined patients prehabilitation. Transplant is a massive operation, and some of our patients physically aren't fit enough still. But obviously, like anything, this requires investment. As I said earlier on, a lot of our assessment previously was ad hoc and done a bit on the hoof. And currently our prehabilitation service is done ad hoc and on the hoof. Our anaesthetists review the patients our assessment patients on a Thursday afternoon in a guaranteed time slot for that. But they lead our prehabilitation service at the moment, which is done on an ad hoc basis. So in order to smarten up our service further and stop it being an ad hoc service for prehabilitation, we need to invest in our prehabilitation service to make that more effective. So we also are going to send out another questionnaire to the patients from the 2 years that we're up to now of a 1-day assessment to find out what their thoughts were, because it might sound great. We might save lots of bed days and found money that we would like to invest back within our service. But if the patients aren't finding it beneficial, then really we kind of need to have a look at that as well. So that's what we've done, and that's where we are, and that's what we want to do going forward. But that's the end of my presentation. I don't know if anybody's got any questions, but please feel free to shout up or let us know what you thought of that. Thank you very much.
Brilliant. Peter, that was absolutely great. Thank you very much. Shall we take those slides down so that we can see you a bit better?
Are you sure? If I exit. Great. Is that better now?
That's lovely. So I'll let people put their hands up. But I guess for me, there were some really fantastic reflections there about the great work that you've done and really some kind of life-saving improvements along that pathway. It was really fascinating to hear you talk about liver transplant. It's not something that I know a lot about, and I feel like I've learned quite a lot as we've gone through that presentation. I really loved the way you talked about how persistent you needed to be as a team. And I love the thought of you nagging for your patients and using that same set of values to be really persistent around making the changes for them. And that values led work really came through everything that you talked about, particularly, you know, things like building your relationships with referral hospitals so that you could improve the pathway for patients, bringing in education, engaging with relatives. There were some really lovely parts of that presentation that you gave us. And that phrase, smartening up, really struck home with me as well, because I think we can all learn from that.
Thank you.
You also were very honest with us, and I just wanted to acknowledge that and say thank you to that. Thank you for that to the team, because you talked about what was difficult as well as what was easy, and you talked about the fact that you didn't get it right first time and that you've needed to do that PDSA improvement. And I think it's just really good to be able to acknowledge that this is a journey. It's not simply moving from A to B. It's about constantly learning and constantly improving. So thank you for all of that you've highlighted there. Ewan, I can see you've got your hand up. Have you got a question?
Yeah, thank you. And I'm sure there's a few people around who will know what I'm going to talk about, the prehab element of this. And I think, you know, I've had feedback from particularly my dietetic colleagues and physio as well, who've really wanted to work as part of this model, and I've had really good success and support from the team, as you say, within an ad hoc approach. And I think the opportunity to really systemize the approach that you've taken here and push it back even further into the community, essentially into the earlier parts of those patients' journeys. And I think the way in which you've focused the improvement work, you know, is, you know, you have shown some really good benefit and improvements. And I love the fact that that patient perspective kind of challenged you as part of that. I suppose but you have demonstrated that there's real and tangible and quantifiable benefits from how you've done this. And I think it does strengthen the argument for saying if we could actually do that more systematically at earlier points in the patient's pathway, the chance of delivering improved outcomes and efficiency for the organisation and the system are ones that we can definitely grasp. So yeah, well done, and it's you know, it's great to hear how effectively the teams work together on this.
Because I think in that pathway we are going to start as well to look at enhanced recovery as a team as well for our transplant patients. So that greater work with physios and dietitians is going to be key in that, in order to enable us to make that happen more systematically, I suppose. I think Emily Bonner has put her hand up a moment ago. She's our consultant anaesthetist. It was one of the key parts that I said at the start of this. I don't know whether she wants to comment more about the prehabilitation side of things from involving the physios and the dietitians, but certainly Tom, our dietitian, is heavily involved and he's very valuable in what we do.
Come on in, Emily.
Yeah, thanks, Pete. Great presentation. Thanks for doing that. Yeah, I just wanted to give a quick update. We were lucky enough actually to trial a formal prehabilitation program. We worked with Ewan and Kath Baker, and they managed to free up a senior physio for us. As everybody knows, prehabilitation is not just exercise, but actually we have so many aspects of prehabilitation already in our pathway. You know, we've got a social worker, we have a dietitian. And really the sort of exercise part of it is the bit that's missing. But in the short time that we did manage to run a pilot for our prehab, we engaged, I think it was 7 patients in the prehabilitation program. These were all patients who'd gone through the transplant assessment process and been deemed not fit enough for listing for transplant. So this is a population that would ordinarily just be palliated, actually, because we couldn't offer them anything else. And actually, of those 7 patients, 5 of them have engaged really nicely with prehabilitation, and we've had 4 of them have subsequently been listed, and I think 3 of them have been transplanted successfully. So those are patients that would never have accessed transplantation without that intervention. So, I mean, I know we're all on the same side with this, but that was really great as a really small snapshot in time of a difference that we can genuinely make to a proportion of patients. And I think I would also second Peter in saying that actually we are looking at enhanced recovery for this. My background is in looking at enhanced recovery for surgical pathways. And what we would love to have is a beautiful streamlined pathway where prehab becomes rehab, and actually all of that comes together. And for this pool of patients particularly, they're really high risk. They've got a lot of comorbidity, but also a lot of social inequality as well. And for that reason, you know, I'm just really happy that we've managed to do that for some patients, and we look forward to doing more in the future.
Thank you, Emily. Ewan, I'll bring you in very briefly if we could.
Yeah, very quick, and actually Emily just referenced a key point, that making the connection between the pre-pathway and the post-pathway is absolutely critical, and that's definitely what we're trying to build. because you improve the outcomes. But that investment in the patient before their procedure and all the preparation and planning is a key part of that health inequalities agenda. And you can enable people to access services and support and give them an outcome that they otherwise probably wouldn't be able to access without that investment of time and an MDT approach in advance. So it's a really important strand to investing well in that preparation phase.
Yeah, brilliant. Thanks, Ewan. And again, just lovely to see how this QI project that you've talked about, Peter, to us today, fits in with all of that other work going on in the directorate and across the organisation. So thank you again for taking the time to share that with us today. It was really fantastic. I'm going to move on now, if we can, to our second presentation, so that we give James lots of time. James, I'll let you introduce yourself. Have you got slides to share as well?
Yes, I do.
Thank you.
Can everyone see my slide?
Yeah, we've got those. Thank you.
Great. Okie doke. So just a bit of disclaimer. So my QI presentation is nothing compared to Peter, but yeah. So hello everyone. My name is James. You can call me JJ, and I'm here to do a PowerPoint presentation about a quality QI project that I've conducted last year, and it is entitled "Staff Wellbeing Promotion Interventions on the Level of Motivation Among Staff in the Workplace Among Staff at Central Operating Recovery." So just to give you a bit of a background. So one of the motivators while I pushed forward this QI initiative was because of the lived experience among staff throughout COVID, and one of the drivers why I've made this happen because of the leadership program that I've attended last year, and I am proud to say that I was given the opportunity to present this QI project at the national level in front of the scholars of the Windrush Leadership Program, and it would be a shame if I don't share this level of information to my home organization. And I'm also a firm believer that knowledge is not knowledge if it's not shared. That's why I'm here. So as you can see on the left side of your screen, that was my QI poster. So without any further ado, so we'll start with the problem. So why did this QI project fell into place? So everything started with COVID. So since the coronavirus pandemic, since 2020, everything wasn't the same anymore. From the way we look after our patients, from service delivery, from COVID guidelines, policies and guidelines, protocols, everything wasn't the same anymore. Second was the NHS staff survey. So the NHS staff survey is a performance indicator tool that conducted annually to measure staff experiences in the workplace. And one of the key performance indicator that it measures is the well-being or the level of motivation and well-being of staff and its trend across the years. And evidence suggests that over the last 5 years, from 2015 to 2020, the level of motivation among staff is getting worse, making 2020 the worst. And locally speaking, in the recovery workforce, during the last 2 years of COVID pressures, there has been movement of staff. So the recovery staff has been sent to ITU areas for staffing support. And last year, during the second quarter of the year, when we thought that we were reaching the end of the tunnel, we were confronted with another challenge, and that is the catching up with elective cases, waiting list, and emergency list, and that resulted to it had significant impact on the level of motivation among staff. So what we were trying to accomplish back there. So in the central operating recovery area, we aim to increase the staff motivation by 10%. We hoped to achieve this increase at 1 month post staff wellbeing promotion interventions. And what did we measure to understand if our change was an improvement? So process measures were utilized to monitor the progress of the action plan, as evidenced by an increased in percentage of staff selecting often or always on the following metrics. One is on how they look forward to go to work. Second, their enthusiasm about their jobs. And third, whether their time passes quickly when working. So what changes would be made? So the staff well-being promotion interventions were embedded utilizing the PDSA approach. So we, as you can see, you got 5 PDSAs in there. So and each after PDSAs, as it was measured using the following metrics through a staff survey. So during PDSA 1, a benchmark summary report from the staff survey was used as baseline data, focusing on the staff engagement or motivation. And also a team meeting was also conducted, informing everyone, briefing everyone that a QI project will be implemented and for them to be aware for them to expect some change in the next few weeks. And then PDSA 2, a staff well-being bulletin was placed in the nurses station where everyone can see for 5 days. And this is to, give everyone a sense of positive outlook while at work, despite the busy department. PDSA 3, thank you cards among staff from colleagues for 5 days. And this is to, give the make the recipient feel valued, appreciated, and important. Hence, it hopefully improves one's well-being. PDSA 4, distribution of fun trivia and quizzes at work for 5 consecutive days. And this is to promote teamwork and staff engagement and to give them a bit of fun really at work in their idle hours. And lastly, PDSA 5, the post-COVID-19 staff nomination awards, which was implemented in a span of 6 days. The department were given 5 days to draft their nominees in each award categories. And on the 6th day, the awarding ceremony took place, and this is to give recognition for the staff for a job well done at work. So the million-dollar question would be, did the QI project made some positive changes in increasing the level of motivation among staff in the department? My answer would be no and yes. No, in a sense that we weren't able to reach the 10% target in increasing the level of motivation among staff in a span of 1 month. And yes, and I will explain this in the next slide. So the impact, for now, I want you to focus your attention on the line graph on the left side of your screen. As you can see, that is the line graph representation, and those 3 lines represents the 3 different metrics that I've used to measure the level of motivation, which is that I look forward to go to work, their enthusiasm about their jobs, and whether time passes quickly when they are working. So as you can see from PDSA 1, the baseline, going to PDSA 2, you can see a noticeable decrease in terms of level motivation, and this is due to the fact that from PDSA 1, we used the benchmark summary tool from the NHS staff survey, which is supposed to be the actual representation in terms of level of motivation among staff, which it turns out the level of motivation among staff in recovery was actually lower compared to the benchmark summary tool. However, if you notice from PDSA 2, where I implemented the staff well-being bulletin, going to 3, 4, 5, where I implemented the staff nominations, you can see a gradual increase in terms of level of motivation. And also, looking at the perspective, starting from the well-being bulletin was put into place up to the post-COVID staff awards, the percentage of people selecting often or always on how they look forward to go to work increased by 32.9%. Their enthusiasm about their jobs increased by 25.9%. And lastly, how their time passes quickly when working increased by 34.3%. Therefore, based from the raw data collected specifically in the workplace, the staff well-being promotion interventions made some positive changes in central operating recovery. Now, if you would refer your attention to the right side of your screen, on the first row, you can see the post-QI numbers, and it goes to show that the post-QI numbers are actually higher compared to our own organization's numbers in terms of levels of motivation. And to put the cherry on top, the post-QI numbers are actually higher compared to the average level of motivation in the NHS across the board. So I think it is fair to say that it made some positive changes. So next slide, I'll give you a couple of seconds to have a look on the personal staff feedbacks given by the staff. So as you can see, the staff matron noticed the staff wellbeing bulletin and wanted to replicate the same concept to the rest of the whole central operating department. And then a member of the team thought that the thank you cards were a lovely idea. Those who were appreciated will always do more. And then people believe that the quizzes trivia help promote teamwork and raise the spirits in the department. And lastly, one staff was convinced that the staff awards lifted the morale greatly in the department. Furthermore, it let their colleagues know that their efforts were noticed and appreciated. What were my learnings and reflections from this QI project? So for one, I was amazed on how people were so invested about well-being. And I think it goes back to the main reason that they felt that this is a need and this is something that we need to focus our attention on. That's why they were invested in taking part, and then they understood the purpose of the QI project, hence staff engagement was achieved. Second, different resources had a significant help for the QI process, and that is utilizing resources such as the Gantt chart, the PDSA tracker, and utilizing a graph to measure, to plot the changes or improvements throughout the QI project. However, the wider picture that caused the motivation levels to be low was partially addressed. And it is because due to the issues like understaffing and heavy workloads were the main demotivating factors among the workforce. And these were the staff feedbacks based from the staff surveys that I've put in as well. And also time constraints were the main challenge as the project needed to be implemented in 1 month because I have to start with this secondment that I am currently in. So what I did to move forward was next steps. So I went back to the department and I did a presentation of the final results to the line managers, to the in charge, to the band sixes, as well to the staff, to the department in general for project sustainability. And it made a lot of difference because from this project they came up to some realistic, pragmatic, and sustainable action plans from this. And one of the important ones was coordination between functional, operating, emergency, theater list according to recovery staffing capacity. So they tailored the theater list according to the operational capacity of the recovery. And then also they managed to tap other department under the same directorate for staffing support. I mean, we've been sent to ITU for staffing support, so I guess it's fair enough to say that now is the perfect time to return the favor, just since we were overwhelmed. And it worked quite well because after the presentation, and the department have seen anesthetic staff, scrubs staff, and even ITU staff who would help the department during peak hours to help. So we were essentially working as one, and also the nurse in charge had a critical role on this and on these steps and the steps moving forward as well by ensuring smooth and equitable patient allocations. So they ensured that patient allocations were made equally and equitably, so nobody gets home overworked. And lastly, daily and also daily briefings. So before we used to do monthly briefings, and during what normally happens was during the monthly meetings, after explaining the updates, they would open the floor for staff issues and concerns, or if there's anything that they would want to raise. But then they increase the frequency from monthly to daily. So just to give them an open and safe space for them to raise their issues and concerns. And also in my bit, I've managed some liaison with the different trust stakeholders, such as the Staff Experience and Engagement Officer, Newcastle Improvement, Flourish, regarding the QI project and Wellbeing and Motivation Initiative. So what would be my QI takeaway? What would be my takeaways from this QI experience? So one would be start small. So QI quality improvement doesn't have to be large scale. You can start in your own departments. I mean, and you will be surprised of the ripple effect that it would cause from just doing small things. Second would be QI is fun and anyone can do it. When I did my QI, when I did this QI initiative, I was a band 5 back then. And for me, I felt like I was nobody. I was just this small stone in the corner. But if I were to put that if I were to put that small stone analogy from this QI experience, I was that small stone at the tip of the Swiss Alps that loosen up and that caused an avalanche. And you'll be surprised and you'll be surprised and on the effects on it. And lastly, health and well-being. This QI initiative may or may not be relevant in your own departments due to the fact that government guidelines says that we have to, live alongside with COVID. But we still have there would be other people or members of staff who would be suffering from residual effects from COVID. And the good thing is, from our organization, we got plenty or we got various resources that would support health and well-being among staff. We get the Flourish agenda, we get the staff well-being, we get all those support mechanisms, and you can even start on conversation starter questions. You can just ask your staff on what matters to you, what makes what makes a what makes a great day to you, and what gets in the way on having a great day. And all those simple questions makes a difference. And all and yeah and those and by those you are looking after the health and well-being among your staff. So it's all about looking after yourself and from your colleagues really. So you'll be glad that's the end of my presentation. Thank you.
JJ, thank you. That was a brilliant presentation again. Very different from the first, and it's lovely to have that mix of quality improvement presentations at one of these sessions, because there's something in there that every single person can do and every single person can relate to. So thank you for that. And I love that picture at the end, because I think one of the things I've written down is around having fun and how important it is to be able to have fun and to identify that as an outcome. Again, I'll leave people to think about any questions they've got. If you'd just like to put your hand up, I'll come to you. We've got a few minutes, thanks. But I suppose the thing that I wanted to pick up on, James, was how brilliantly you use data and measurement in that, because that's something that we find really difficult sometimes, particularly with staff wellbeing. But you gave yourself a really ambitious target to work towards, and it was really good to see that you'd measured that very systematically over actually what was quite a short period of time.
Yeah.
But we're able to make some really good improvements. And the other thing that really struck me was how that focus on well-being for individuals has some of those really positive impacts on other parts of the service. So you talked about the benefits it has for allocations and making sure that people do their fair share and don't get overwhelmed. You talked about the benefits for openness and being able to have different conversations, and for cross-directorate working as well, which are all things that you perhaps might not have thought would come out of the piece of work, but absolutely did. So well done, that was really good. Do we have any questions from anybody? No? You've obviously answered everybody. Oh, hang on, Moya, would you like to pop in?
Hi JJ, well done. You've done some great work there. How are you going to keep it going?
So yeah, I wish I could from the recovery point of view, I keep on monitoring in terms of level of motivation, and I'm thinking of using the same measurement tools as well to measure the level of impact in terms of level of motivation. And that's why I was so motivated and enthusiastic to have this learning and sharing event. So hopefully we can embed mental health and well-being throughout the organization as well.
Great, well done JJ.
Thank you.
Thanks, JJ. Well done, and well done to everybody who's spoken today and who's been part of those processes. It is most definitely the best part of my week, to be able to hear about that fantastic work that's going on. And I suppose just the thought that I'm really taking away is something that JJ said in that last presentation about him feeling like he was a small stone in a corner. And I could see around the screen lots of people nodding and smiling when you said that. Because I think we all feel like that sometimes, don't we? It's really easy to think I'm just one person, I can't make a difference. And it's brilliant to have an hour over lunch and 2 really inspirational stories to remind us that actually the only thing that ever makes a difference is one person making a change and taking responsibility. So that sits as a challenge for all of us and as a reminder for all of us, and it's great to do that as a community because we can all support each other. Joe has put a link in the chat. This is, I think, coming to the end of the first few of these sessions that we've arranged. So we would love to know what people have thought about them, how we could make it better, what you've learned and how you've put that into practice. So there's a link in the chat. If people could just take a few minutes to click on that and to answer those questions, and then we can really make sure that these sessions are as valuable as they possibly can be. As I say, we've got this recorded, so we'll share it with people. So if you have enjoyed this, if you've found it helpful, please do let your friends know, let your colleagues know, share it with them, and hopefully we can really spread that message around improvement and build the community.